A very good evening to one and all. Welcome back to the today's session. Today's our guest speaker name is Dr. Neha ma'am. We welcome you ma'am. We welcome you all the participants. Over to you Ashika.
Hello.
Yes Ashika, you are audible. Please continue.
Good evening, everyone. So it's my pleasure to introduce today's presenter, Dr. Neha Patel, ma'am, who bring extensive experience as an academics, in academics also, as a clinician and researcher in the field of homeopathy. Dr. Patel, ma'am, holds an MD in homeopathy from ML Dhavle Memorial Homeopathic Institute, Palghar, and she has done her bachelor's degree from CMPH Medical College, Mumbai. She currently serves as an associate professor in the Department of Case Taking and Repertory at CMPH College, and also she is consultant at Shri Mubadevi Homeopathic Hospital. Her research includes over 15 peer-reviewed publications in national and international journals covering areas such as essential hypertension, global development delays, type 2 diabetes, and migraine. She has presented at several national and international academic platforms too, including World Homeopathic Day, which was celebrated, and World Ayush Exponent also, and LMHI conference also. Her MD dissertation on psychosomasis of uh, psychosomasis of hypertension received recognition from Central Council of Research in Homeopathy as quality dissertation too. In addition to teaching and clinical work, she serves as an editor at CMP Healing Journal and is active member of several institutional committee, including ethics and medical education. So everyone, please welcome Dr. Neha Patel, ma'am. And over to you, ma'am.
Thank you, Ashika, for a wonderful introduction. Are my slides visible again?
Yes ma'am, slides are visible ma'am. The session is all yours ma'am. Thank you ma'am.
Thank you. So today I'm going to present a topic where you're going to understand the psychosomatic and psychodynamic dimension of migraine, emerging insights and role of homeopathy. Migraine, as you all know, is a cyclical disorder which has different phases. The different phase is something that we're going to study today. It's said to affect 1 billion people worldwide annually, where females are 3 times more likely to suffer from migraine than men. And it is the second largest contributor to disability adjusted life years, having an economic impact. Yeah. So that brings us to the question, at what point does a patient's presentation warrant a migraine diagnosis? At what point will you diagnose a patient as having migraine? Like say suppose if we give an example, like a patient comes to you at your clinic presenting with unilateral one-sided headache, which is very intense, pulsating, throbbing type, but just started since an hour ago. Will that warrant a migraine diagnosis? I would like the session to be a little interactive. So if we could have some answers in the chat bar of that, when can we diagnose the patient as having migraine? Yeah, can we have some answers in the chat box, please? Okay, if no, then when? Karishma. You could just share some light to when can we. Okay, it should be chronic. Duration of the pain matters. Okay. Apart from the chronicity and the duration, is there any other factor that matters? Triggers matter. Okay, the unilateral pain matters. Yes. chronicity matters. Okay, so I think we have good amount of answers in the chat box. Let's move ahead and let us understand what can help us diagnose a patient having migraine. Yeah. So we have an international classification of headache disorders, which have given classification for migraine as migraine without aura, with aura, chronic migraine, complication of migraine, probable migraine, episodic syndrome that may be associated with migraine. Yeah. So in order to diagnose the patient as having migraine without aura, the patient must fulfill the following diagnostic criteria. Yeah. The very first criteria is at least 5 attacks fulfilling criteria B to D. So the very first attack, as I just mentioned in the example, if the patient is coming to you with the very first time experiencing an intense headache, may not warrant a diagnosis of migraine. Yeah. So if you're diagnosing a patient of migraine without aura, it requires at least 5 attacks. Criteria B says that the headache must be lasting for 4 to 72 hours if untreated or unsuccessfully treated. Yeah. So as mentioned in the example, if the patient is having a headache from half an hour to 1 hour, unlikely that it would be a migraine attack. Yeah. So this is something that is important. The next is the headache has at least two of the following core characteristics. I think of which many characteristics were mentioned in the chat box. And it should also include at least one of the following characteristics as mentioned and not better accounted for by other classification, yeah, other diagnostic classification. So if the patient fulfills these criteria, that is when you can diagnose your patient as having migraine without aura. Coming to migraine with aura, the diagnostic criteria is at least 2 attack fulfilling criteria B and C. So if you see in migraine without aura, there were 5 attacks. Yeah, and here we see that even 2 attacks when the migraine is having with aura are, and if there are 2 attacks fulfilling the following criteria, we can diagnose it. Criteria B says one or more of the following fully reversible aura symptoms. So the aura symptoms which are experienced by the patient either before or during the headache, once the headache is over, should be fully reversible, should not continue. The aura symptom can be visual, sensory, speech or language, motor, brainstem, retinitis. At least 3 of the following 6 characteristics must be present. That is, at least one aura symptom must spread gradually over 5 minutes. 2 or more aura symptoms occur in succession. Each individual aura symptom can last for 5 to 60 minutes. At least one aura symptom is unilateral, one aura symptom is positive. Now, what do you mean by aura symptom is positive? Something that we're going to deal with in the later segment. The aura is accompanied within 60 minutes by headache.
So I think we went to migraine without aura, right?
Yes, ma'am.
Migraine with aura is something that we finished last.
Yes, ma'am.
Yeah, since it just got disconnected in between. Okay, so we'll continue with migraine with aura then.
Yes, ma'am. Please continue, ma'am.
Diagnose a patient having chronic migraine. As I mentioned, the chronicity is very important. The chronicity, as mentioned here, is 15 days a month for more than 3 months, fulfilling the criteria as B2D for migraine without aura and B2C for migraine with aura. And 8 days a month for more than 3 months for migraine without aura, the criteria is C and D, and for migraine with aura, the criteria is B and C. Yeah. And it is not accounted for any other diagnosis. We also have a diagnosis of probable migraine with the diagnostic criteria we're fulfilling all other criteria except one, not fulfilling any other criteria of headache disorder and not accounted by any other diagnostic classification. That brings us to the etiology, which I actually cannot see myself here and I can't hear also. So if there's any issue, please mention it in the chat box. Yeah. Kindly mention it in the chat box if I'm not audible or if the slides are not visible. Yeah. Migraine is believed to be a combination of genetic, environmental, and neurological factors. With genetic predisposition, a specific gene variation increases the susceptibility to migraine, making individuals more likely to experience them when triggered. Yeah, this genetic predisposition is a concept which is very close to our homeopathic concept of predisposition also. Yeah, so whenever these patients are more predisposed when triggered to develop migraine. Then we have the neurological factors where abnormal brain activity, chemical imbalance, or role of peptide play a very important role. We have trigger for migraine, stress, hormonal changes, environmental changes, sensitivity to smell, skipping meals, lack of sleep, alcohol, smoking, chocolates, bright lights, dazzling lights, sunlight, or sexual activities are known to trigger migraine. Yeah. Although the pathophysiology of migraine is not fully understood, it is said to be a combination of peripheral and central nervous system component being involved. So, as per the old vascular theories, the headache are caused by vasodilatation and auras by vasoconstriction. Then we have another theory of trigeminal efference. Once stimulated, it releases pro-inflammatory mediators, which causes meningeal, cortical, and cerebral event, which triggers headache. Then there's a role of peptide, as we discussed in the etiology, which causes headache. Then that brings us to the understanding of history, like how will the patient present to you? Yeah, what is the patient presentation when he comes with a complaint of migraine? So typically it has 4 phases. The prodrome phase. Now the prodrome phase is seen in 77% of the patient and the symptom lasting from 24 to 48 hours before the onset of headache. This is more commonly seen in females than males. The common symptoms include yawning, mood changes, lethargy, neck stiffness, sensitivity to light and sound, restlessness, difficulty focusing vision, feeling cold, cravings, sweating, increased energy, thirst, and edema. Yeah. So these are very important to note as the prodromal symptoms. Otherwise, you might mistakenly take it as a characteristic symptom happening, as a modality which is happening or associated symptom happening before migraine. You can also take these rubrics, but here, since we know that it's a common symptom, we really must not take it, since these are the symptoms which are commonly experienced during the prodrome phase. These are the symptoms which are experienced during the aura phase. Yeah, and we, as mentioned in the diagnostic criteria itself, that auras lasting usually less than 60 minutes. So visual auras are more common. Sensory auras are also common. It can occur with visual aura or independently. Language auras are infrequent. Motor auras are rare and involve complete or partial hemiplegia, and aura by definition are reversible. Means all these symptoms which are felt will no longer be felt once the migraine attack is over. As in the earlier segment, right, we were discussing, when we were discussing the diagnostic criteria for migraine with aura, we mentioned that there's something called as positive symptoms. So positive symptom includes bright lights, shapes, noise, paresthesia, or allodynia, which are being experienced by the patient. Negative symptoms include lack or loss of function, reduce or loss of vision, hearing, sensation, or movement. This is a pictorial and a tabular format for visual aura. Yeah. The next stage after aura, as we all know, is headache. This, I think we all know that the headache is unilateral, pulsating, throbbing, increasing in intensity, associated with nausea, vomiting, photophobia, phonophobia, rhinorrhea, lacrimation, allodynia, osmophobia. The headache can last for hours to days. The patient may seek relief in dark place, and the pain usually resolve with sleep. And there's something called as postdrome. Now, this symptom is felt by the patient once the migraine attack is over, postdrome. Like we had a pre-drome phase, yeah, where we understood certain common symptoms felt in the pre-drome phase. Like that, we have the postdrome phase. So typically in postdrome phase, there's no pain, but whenever the patient moves, this pain felt exactly in the same location as the patient experienced the headache. The common symptom includes exhaustion, dizziness, difficulty concentrating, and euphoria. That brings us to the question of evaluation. Yeah. So, how do we evaluate a patient having migraine? Or rather, do we evaluate a patient having migraine? And if yes, how? Now, with this, we can have some answers in the chat box. So, I can also understand that my slides were visible and I'm audible. Yeah. That's the only way to understand that so far my slides were visible and I was audible. Okay, so if yes, how do we evaluate? Yeah, how do we evaluate a patient having migraine? Thoughts, any ideas on how the evaluation should be? That is what we're trying to understand here. On what basis the evaluation must be conducted? Yeah. Very first thing, as we all know, the diagnosis of migraine is based on the patient history. Yeah. What will the patient present with is something that we just learned, right? So those were the presentation that the patient will come up with, the physical examination that we do for every patient, and the diagnostic criteria. Fulfillment of the diagnostic criteria is very important, that we have discussed earlier. The next is the neuroimaging, like CT, MRI, MRA, and MRV. But then comes the next question, does every patient having migraine require neuroimaging? Or how do you decide which patient require neuroimaging? Yeah. Can we have some answers for that in the chat box? Which patient require neuroimaging then? If you're not sending, okay. For migraine headache, which patient having migraine headaches, how will you decide that that patient requires neuroimaging? Okay, right, absolutely right, Karishma. When you're suspecting tumors or malignancy, Aneurysm, yes. So now we have an acronym, yeah, called SNOOP to determine the neuroimaging indications, where S stands for systemic signs, symptoms, and secondary risk factors. So if any patient is having any systemic sign and symptoms or secondary infections, the secondary risk factors, then that is when you will go for neuroimaging. The next is neurological symptoms. Yeah, neurological signs and symptoms. I think the disease condition was already mentioned by participants in the chat box. There's a general where we say there's any neurological signs and symptoms, we'll send the patient for imaging. Then onset, when there's a very sudden onset, an intense headache, yeah, at times it can be an indication of stroke. So that is where we are actually trying to understand whether it's what exactly is the pathophysiology happening. So that is where you can go for neuroimaging. Older patient, yes, you have to go for neuroimaging. And when the position dependent intensity changes are seen, or pattern changes, papilledema, or whenever it is precipitated by your Valsworm maneuver, that is where you go for neuroimaging. Yeah, so this is a small acronym that we made which helps us to easily remember when to send your patient for neuroimaging. Let us take a case study. We have a 38-year-old female who's complaining of recurrent headaches for past 12 years, which were worsened since last 18 months. And these are the characteristic of her headache. These are the headache characteristics as seen. That brings us to the question of diagnosis, right? So what is the diagnosis? Now, since we already learned that your patient have to fulfill certain diagnostic criteria, and we have already learned the diagnostic criteria ahead. So if we could just have some answers in the chat box looking at this history, the clinical history and symptomatology, what do we think is the diagnosis for this patient? Yes, as per the diagnostic criteria, what is the probable diagnosis that you're yeah. So chronic or a chronic migraine, that is what you mean, right? So yes, definitely. As we know the duration here and the frequency, and we have studied, so this definitely accounts to chronic migraine. Yeah. And also, does it require any evaluation? Whether you have to send this patient for neuroimaging, so that is also answered. Now we're trying to understand, since we're trying to understand the psych and soma connection, we're trying to understand the genesis of migraine. So how did the genesis of migraine took place, right? So the life event we have that in the very early life, the parents, though physically present, were emotionally distant. So the patient felt unseen and unheard. Whenever she showed any sadness, she was called too sensitive or too dramatic. Yeah. And that is where she learned to hide her feelings. And that because whenever she shared her feelings, she was said either she's too dramatic or too sensitive. Recalls watching her younger siblings being comforted when upset, but she was being told to toughen up. With all these experiences in her adolescence, she understood that love can only be earned through sacrifice. And that is where she became responsible, took up cleaning, supporting siblings academically and emotionally. In school, she had a lot of exam anxiety. She was intelligent but uncertain. She would second guess herself. In adulthood, she was the only one who's holding everything together. She would work part time, manage the house entirely without help or recognition. Music, strong smell of flowers, household clutter, or disrupted routine would make her anxious, especially during full moon. And the only relief that she got was through weeping. Small daily frustrations like misplacing an item, a careless comment can spiral into an emotional overwhelm. She lives in a state of hypervigilance, restless, anxious, unable to relax without guilt. The other thing which was there in this case is she would feel better by expressing her emotions. Yeah. But since the parents, right from an early childhood, they was devoid of love and affection, so she had difficulty in expressing emotions. But she mentioned it very clearly. If she expresses her emotion to anyone, that is where she'll feel completely better. Yeah. That brings us to the question of how will you understand, how will you identify the personality traits? What early life experiences might have shaped these traits? How does her personality influence her migraine? What does her headache symbolize? Yeah, so can we take one question at a time? We could have some answers in the chat box. Yeah, how are you identifying the personality traits? Like, what kind of personality does she have? Some answers in the chat box. Yes, responsible. Zing. Yes, of course. Any other personality? Okay. So here we say that from the life event itself, we understand that she is very responsible. Yeah, she like there was devoid of love, and that is where she understood that she have to sacrifice, and that is where she developed people pleasing. Exalthymia is when a person have difficulty identifying and verbalizing her feeling, and here in this case we saw that the patient will feel relief only through crying. And emotionally reactive, where even small issues as mentioned, yeah, will cause her anxiety and unstable mood. The next question is, what early life experiences might have shaped this trait? Yeah. So the question is, what happened in her childhood that helped shape these personalities? Yeah. Any answers for that in the chat box? What were the childhood experiences that were faced by the patient? Any childhood experiences? Young age responsibility, suppression? Yes, definitely. No emotional support. Yes. So we see that initially the emotional support, as mentioned, is absent, and that led to a lot of emotional suppression. And she was praised only when she did anything good or when she was helpful. So that led to a people pleasing behavior. She was criticized for expressing her emotion. Yeah, we saw in the life event, she was told too dramatic, too sensitive. That is where her self esteem became low. She took up responsibilities, and there was a lot of submissiveness seen. Now, these suppression of emotions, yeah, made her feel that validation, like there's lack of validation, which taught her that emotional needs were burdensome and shameful. Now, how does this personality influence a migraine? So we see that with people pleasing, there's a lot of emotional suppression, there's anticipatory anxiety and hypervigilance. With this emotional suppression, there's a lot of muscle tension, autonomic arousal, and development of migraine. So we see how symbolically the inner distress, yeah, the inner distress is expressed as symptoms of migraine. So her migraine symbolizes her unspoken grief, the mental overload, and the silenced need. Yeah, her emotional need was silenced, and that is what her headache symbolizes. Hmm? This, the next that we come up to is what, if by now you all have reporterized the case, what all are the group of remedies that you all are thinking for this patient? Yeah. Any group of remedies that you can think for? Okay, calcarea, lac group, yeah. This is the reporterization. Here we have taken just characteristics that are seen in the life event and the characteristic as mentioned as modalities for the headache. Yeah, the predominant remedies coming up for graphitis, lycopodium, sulfur, and nux vomica. After this, we went back to the materia medica. While reading it from, like, see, we are trying to understand the psychodynamic and psychosomatic. Yeah. And from the life event, there were a lot of emotional suppression that we see in this patient. So we're going to the materia medica, which helps us understand the remedy. And here in this remedy, sir have written that the patient have marked amelioration from weeping, just like how our patient has. Yeah. And you've also mentioned that how she feels completely better when she expresses her emotion, which was there in our patient, where especially when in our patient, which was unable to express her emotion. Yeah. So that is where graphitis as a remedy was given to this patient. This was a brief summary of the follow-up. I could not mention the entire follow-up here. So what I've done is I've summarized the follow-up. So after taking the medicine, the frequency and intensity of the headache have decreased. Yeah, if you remember, the previous frequency was almost 10 to 12 headaches every month per day. So that have reduced to 1 to 2 every 3 to 4 months, and the intensity have gone down a lot. Yeah, like her response, she feels very positive. She feels that the functioning is improved. There's another thing which was mentioned was there were disabling episodes, means because of the headache, she could not function. It may be the daily household or the part-time work that she was doing. There were no disabling episodes which were seen after our medication was started. Yeah. So our medication not only shortened the duration of headache, it also allowed her to remain more engaged. And although the emotional and sensory triggers remain, the patient had mentioned that she feels a sense of relief and control, and she have not experienced something like this previously. And that is something which I think no other medicine will help the patient with. This is something that only when homeopathic medicine given, these are the experiences that the patient will share. Yeah. Let us take another case study. 32-year-old boy having headache from past 8 to 10 years and significantly worsened from last 8 months. Yeah, this is the clinical history, the headache characteristics. So you see that the occipital headache radiating forward to forehead, the tearing type of pain talks about the severity. Almost 15 days means almost half a month he's having headache, which is more during motion, contradiction. Yeah. So diagnosis, I think by now you'll are masters. You all know that this falls under chronic migraine. Yeah. So to understand the life event here, he was only 8-year-old when his father died. So he being the eldest, he stepped into his father's shoes and became the responsible one. So he started taking care of his siblings, the mother, of himself. He would wake up early in the morning, dress up neatly for school. He would carry his school bag with pride and responsibility. Neat, punctual, and reliable. Conscientious to a fault. Every grade mattered. Every mistake was a moral failure. He didn't just want to succeed, he always felt that he had to do it. So here we see that the love and affection were tied to performance, where he felt that only if he performed well will he be loved. And that made him very duty bound. Yeah. He rarely allowed himself rest. He developed a strong internal compass, but it pointed only towards duty and never towards joy. In college, he studied harder than anyone. He pushed beyond fatigue, skipped meals, ignored headaches, and the headache worsened, especially when he moved too quickly or when contradicted by others, especially by those who don't understand his drive, his ethics, and his need to be enough. By adulthood, he was the backbone of his family, financially stable, morally upright, and emotionally exhausted. He had become the man defined not by desires but by discipline. With this, these are the same four questions that we'd answered for the last case. Personality traits. Yeah. So in this case, what are the personality traits? What is the personality of this patient? Can we have some answers in the chat box? Some quick answers in the chat box. Yeah. So by now you understand how we are identifying personality traits. So how are we identifying the personality? Yes, the perfectionist. Yeah. Hardworking. Yes. Very hardworking. So if you understand the personality traits, as mentioned, he was a perfectionist. He had difficulty identifying his emotion and expressing them. Self-sacrifice that he did to uplift his family. He was hyper conscientious, control oriented. Yeah, he wanted to control his environment, appearances, and behavior. So as far as the early life experience go, we know that the parental loss, the family dynamics, due to an absence of his childhood, but he took up responsibility too early. The scarcity and survivalism, yeah, economic and emotional instability further reinforced and made her to become the perfectionist as a survival strategy. How does this influence his migraine? The inability to rest, the unrelenting self-pressure, the pressure that was not given to him by others, but something, a role that he took upon himself, and the pressure that he feels with that, the emotional suppression and the sensory sensitivity to chaos or contradiction. Now, these together led to the development of migraine. So here again, we see how the internal distress, yeah, is seen as migraine. So his headache symbolizes the repressed emotion and grief, and a metaphor for mental overload and a desire for control. What are the remedies? Can we quickly have some answers in the chat box? What are the group of remedies that you're thinking for in this case? Asia, yeah. Okay, MAC group, yes. Kali Karp, okay, yes. Kali group, yes. Lycom, okay. So this is the repertorization. Yeah. So here as we see that it was mentioned the tearing type of pain with the modalities. So you can't see the entire rubric here, but what we have taken here is the characteristic radiation that he had here, where the pain was tearing type and extending from occiput to forehead, and the two modalities that he had, the motion and contradiction. Apart from that, the very um, three prominent mental symptoms that we noticed in this patient through the life history, the conscientiousness, the contradiction where it aggravates him, and strong sense for duty. So that brings us to Aurum, Nux vomica, Ignatia, and Lyco. Yeah. And as we say that we go back to materia medica to differentiate, we're reading this remedy, Aurum. Now there's something called a situational materia medica. This is again taken from Sir's book, where Sir have written very beautifully, right? That Aurum is a situation in which his survival is dependent on fulfilling his duty. Aurum is the eldest child of the family and his father is no more. The society will blame him if he does not take charge of his sibling. So he raises the family and he's the duty bound son. Yeah. The duty bound son, his views are very moral and conscientious. And somebody mentioned Silesia, and very beautifully it is differentiated here, where Sir writes that Aurum is concerned about how he appears to himself. He always checks whether he has done things right, since his survival depends on this, and not how he appears to other people. So Silesia being very image conscious, he is more focused on how he appears to other people, where Aurum having a strong internal compass and being very duty bound and conscientious, yeah, he feels how he appears not to other people. Yeah. So here also I've concised the follow-up where we see the reduction in headache frequency and severity since initiating the medicine. A headache for 2 to 3 episodes, 3 to 4 months. Previously, it was almost half a month, right? The intensity were also milder. And if you remember, it was last almost the entire day, but no episode after taking the medicine will last for the entire day. Yeah. And also, he described as feeling overwhelmed and more hopeful. So those are the changes that were noticed after the medicine. That brings us to the very last segment where we're trying to understand the psychosocial life events linked with migraine. So it is said that the early life experiences like physical, emotional, or sexual abuse, parental loss or neglect, emotionally invalidating environment, childhood trauma increases the risk of migraine. Yeah. And recent stressors like workplace burnout, marital discord or separation, financial insecurity, role strain, especially in perfectionist caregivers, bereavement, relocation, retirement. These life events often precede the onset or escalate migraine episodes. Personality trait like our perfectionism, as seen in the case two, the difficulty identifying and expressing emotion, exalthemia, which was seen in both of the cases, anxious, cautious, over control behavior, anxiety was seen in both the cases, over control behavior was seen in the second case, tendency to negative affectivity and emotional instability seen in case one, people pleasing behavior seen in both the cases with suppression and submissiveness. Now, these traits will predispose the individual to emotional suppression, which leads to somatization. So, what is somatization? It's a defense mechanism. Yeah, but the emotional pain is channelized to bodily symptoms. The repression, as seen in the very second case, yeah, where we saw that the person is repressing his emotion and the development of migraine. Reaction formation is when the you're feeling one, but when you're expressing the complete opposite feeling, it's called reaction formation. Denial, as the word suggests, you're just refusing to acknowledge emotional triggers. So your patient will say that I'm not stressed, I'm just having migraine. Projection is attributing one's own feelings to others, means what you are feeling it, you are attributing that the other is feeling about you. That is projection. What are the coping style is an avoidant coping. With avoidant comes denial, suppression, distraction. So if your patient is having an avoidant coping, it will increase the attack frequency and will have poor treatment response. If it's emotional focused coping, like we had in case 1, where she felt better by emotional weeping, that have mixed outcome. Problem focused coping, as the name itself suggests, will have better long term adaptation. Passive coping, like helplessness, resignation, will predict chronic migraine and disability. Common migraine triggers which were seen, yeah, the emotional triggers were unexpressed anger, grief, unresolved loss, guilt and self criticism, anxiety about performance or failure, frustration due to perceived helplessness. Those were the common emotional triggers seen. Yeah. And these are the key references taken. I would like to thank for the opportunity given to me for presenting this. Yeah, if you all have any questions, you can get back to me on this email ID mentioned. And I would like to thank the participant as well for sparing the time. And I would like to apologize for the technical glitch. Yeah, thank you. Any questions?
Thank you, ma'am. Thank you, all the participants, for the excellent interaction. And if there are any questions, just comment in the comment box, so madam will be answering.
मैडम क्या हिंदी में क्वेश्चन पूछ सकता हूँ?
I'm so sorry, I can't hear you all.
कमेंट बॉक्स में कमेंट करिए सर.
Hello?
Yes,
Hello?
ma'am. Yes, ma'am. Am I audible
Hello?
to you, ma'am? Am I audible, ma'am?
Okay, I can't hear you, but am I audible to you all? Okay, okay. Yeah, yeah. So if I'm audible, the question is lycopodium. For the second case, are we talking about the case 2 or case 1? Okay, case 2. We're talking about case 2. So to begin with, yes, lycopodium is something that you can really think for that case. Yeah. But if we start from the perspective of the life history, lycopodium will definitely cover the conscientiousness and contradiction aggravation is definitely seen in lycopodium. But if you understand the duty boundness that was seen in that patient, yeah, so how the entire genesis happened, that was something that I think lycopodium did not include. The other thing was the characteristic symptoms of headache itself with its modality. So if we just take even the characteristic headache complaints, those were something which were not included in that. The other thing for lycopodium, as we all know that over time, there's the strong sense of the moralistic compass that was there with duty boundness. In lycopodium, we more have a diplomacy where he's more, with the superiors, he's very nice. the one who are at a post, if he's at a higher post, the post where people are holding higher than him, he's very nice to them. But with the others who are having a post lower to him, he's not that very, he's not the same.
Any other
Am I
questions from the
audible?
participants? Any other questions from the participants? Kindly comment in the comment box.
Yes, any other questions? Carcinosin, yes, definitely. Carcinosin is a very close coming remedy for case 2. Yeah. But again, if we try and repertorize the case, especially the characteristics seen at the level of the diagnosis, where we take headache and we try to understand what were the characterizing symptom. So if you just even repo were seen in that. The other thing is the completely covers is the conscientiousness that was seen in that patient, where carcinosin definitely comes up. But if we understand carcinosin, it is something where he's trying to. There's a lot of chaos and he's trying to bring everything together, right? So that is where we understand carcinosin as a cancer myosome which is seen. If we understand it from that angle, so that was something which was a bit lacking in this case. So if we understand the complete picture of how the headache and how the genesis of migraine happened, so that entire story, as also mentioned in the differentiation where we study the situational materia medica, right? So even in that situational materia medica, we saw that carcinosin was no matching with the genesis of how migraine developed and how the life events unfolded and how it led to development of migraine. Yeah. Any other questions? There's one question in the chat box. Okay, Suchita, I'll definitely get back to you. We can get back on. मैंने अपना email ID share किया है. Yeah, you can get back there. I'll definitely answer your question. I'll share my email ID here as well. You can contact me and we can have a word.
Thank you so much, ma'am, for the extensive session. Thank you all the participants for your extensive support and overwhelming response. And thank you all. So we'll be back soon with the other session on Saturday. So thank you all. Thank you. Thank you, ma'am. Thank you all the participants.